Hello, thank you for joining us to learn more about team-based care. My name is Kelly Robinson. I'm the quality manager at Utah Partners for Health, and I'm here to give you an idea of what we do and hopefully share and learn about best practices from you. Our mission, like a lot of your missions, are to provide compassionate care. We see a lot of underserved individuals and families. And our vision really here at Utah Partners is to fill the healthcare gaps in the community. So we see a lot of patients that might have been seen in an emergency room. And our vision is to really divert that care and help the community in that way. Most of our community served are Hispanic. We have grown into 3 clinics. We started out in 2002, but now we see over 6,500 patients. 60% report that they're best served in Spanish generally. And last year we had an 80% uninsured rate. So I am located in our main office in Midvale, and the picture up here is a picture of our Midvale office. It's in beautiful downtown Midvale. It actually is really an interesting old town. They've kept the feel there. In that office, we have administration, dental, and our social worker. So here's a picture of our dental team out. We also have 2 mobile vans. One is for medical conditions, and we see our primary care provider there sees a lot of different issues, and she can refer out to specialists in the community and back for lab work at our clinics. But this clinic is for uninsured and Medicaid and Medicare, and doesn't take any copays. We also have eye care, and this has been seen by HRSA as an important part of health. And we're actually expanding from our mobile clinic into an actual optical center. We've seen really great success stories in our eye clinic with kids who were not able to see when they walked in, and we're able to get them glasses so that they can excel in school. Our new clinic we just opened up is right here. It's West Jordan. That's where our eye clinic will be housed. And it also will have a new pharmacy. So we're really excited about that about the team-based care that can happen with a pharmacist in our clinic. Our first brick and mortar clinic is Mid-Valley Health Center. And I always thought it was really unique and interesting because it's located in Copperview Rec Center. So here you are, a clinic that also has a park, and there's a food bank located there too. So this has really been our hub for years and years until we opened this West Jordan clinic just last year. So our team-based care, like I say, started in the Midvale clinic. And how do we use the food bank? How do we become a real big part of this community, somewhere where people know they can go? And when we saw is that we had a really, really high number of patients with diabetes and hypertension. So through a grant, we were able to hire an RN coordinator. And that RN started, and it was kind of a slow process, but started working with the providers and letting them know that she could follow up with these any of the hypertension and diabetes patients. And she became certified in diabetes self-management program. I think it was 2018. It might have been 2017. Again, we have 80% uninsured, but so we're not able to bill for that service necessarily, but we felt like it was a best practice and that was a big way for us to start this team-based care. And it took a while for us to show that, how do you start referring to this provider, to this RN? How are the provider and the RN going to work together? And then about a year later, we added community health workers, and then just we had a licensed social worker, but about the year after that, we decided to try to really roll in a social worker as part of this team-based care and do what we call brief interventions. So, when you see people, it's not all about diabetes. They also have stress and depression. And so having that well-rounded team really helped us become a true integrated care program. Our major challenges, like I say, I think it was a little hard for us to identify the best methods for referrals. Um, just this year, huddles have become a lot stronger and a different way for us to all touch bases and really make sure that we're getting that person that came in to see the provider over to see our community health workers. One thing that's really helped with that I wanted to mention is we were able to hire some more health educators. So they can scrub the schedule, and then having extra hands to go in and say, okay, we looked at the schedule. We know that Kelly's coming in today. We've seen her before. We think we'll have to see her again. Then the providers know to adjust the schedule a bit so that they have time to go see our health educators, go see our licensed social workers. I think our first step for making those huddles work were telephone encounters in our EHR. Those are always seen by our providers, and they're very much embedded in the patient notes. So that was a pretty good tool for us. That was our trick to then become, seen as really part of the team. We're still working on ways to integrate the LCSW. And the main issue there is they're so busy, they don't have time for the brief intervention. They're scheduled. So then when we need them, it's hard to pull them out of appointments. Our answer to that is to try to hire another LCSW. So we're working on that right now. And then documentation is always a big challenge. How are we going to document the work we've done and how we're doing it? We added a prepare light for the social determinants in our EHR, just added it as another template so that our community health worker pulls it in and populates that template. And again, finding the time to document is just something we have to really train on and impress the importance on a regular basis. But those have been our major challenges. I'd say our major successes have to do with, once we saw the success and everyone understood how the team worked together with diabetes and hypertension, we expanded into medicated assisted therapy and substance use disorder. A lot, especially our providers, are pretty excited about the changes they can see in these people. We actually have expanded our team-based care and really tried to coordinate with prison case managers and let them know that we care. And if you discharge somebody, you can in-charge them right to our RN case manager, and she'll help them get the proper medication. They work right with our counselors. So it was nice to have something in place, and then we were able to kind of roll it into other programs. And on that same note, our providers have become a lot more of a champion for this program and for working together. It's ultimately become part of the culture where they see that they can get help from other people to really follow up with the patients. And after we hired the RN case manager and the community health worker, a couple years ago, Utah Partners for Health had one of the rare 80% hypertension control rates. It stayed in the high 70s, except for COVID year. And so I think it's really had some sustainability too. So one thing I've seen as I've been working and looking at team-based care initiatives is people want to know how you fund it. So if you have Medicare patients, the wellness visits are a way I've seen other clinics in the community fund these kind of visits. Doesn't have to be a provider that does the wellness visit. And a lot of times those questions that they ask in the wellness visit are just so comprehensive and they roll into everything else we're doing. And so a nurse can do that. And you can fund her pretty well with wellness visits. For us, with having very few people with insurance, we work for the Federally Qualified Health Center, and there are grants like the AIMS grant that you might want to look into. Some suggestions we have is to hire based on personality. Some licensed clinical social workers are really taught to sit one-on-one with patients. And the kind of social worker you want in this kind of team-based care is somebody who can be pulled away, who will see that we might have a quick intervention with someone who is feeling really depressed about diabetes. And we started addressing diabetes and then found out that they are getting a divorce and feeling suicidal and perhaps having immigration problems. Housing problems are a big thing we see. So find people that are team players that care and will go out of their way. You kind of have to be like that to work at a federally qualified health center anyway, but we found that to be really critical for helping the team. And then always just make sure when you're starting, have a baseline, because being able to show, before we had our RN case manager, here's what our hypertension rates were. Then we hired those health educators and RN case managers, and we saw this kind of improvement. So that really spoke to our providers and was a big success for us. Just the other day, we had a success story I wanted to share. I was walking into our dental office, which is also our admin office, and the health educator was with me. And we saw a patient who had been tested for blood pressure, and he was denied care because his blood pressure was so high. So the patient was looking at us and wondering what, like, kind of looking at, and it ends up he knew the health educator because he had been talking to her about high blood pressure. And he was so sad because here you are coming in to get your dental work done and you're being denied. Perfect example of how we try to work as a team. Our dental staff knows that if their blood pressure is high, they get them to the clinic. So they're rolled in on all of our help. So he saw our educator. She was happy to see him. She grabbed her laptop, took him to a conference room. She spent about an hour and a half talking about resources, listening to him, just kind of counseling him. And she found an appointment with a provider for the next week. And then she sent him over to our RN where the blood pressure cuffs are. And we have some loaner self-monitored blood pressure cuffs. And when he got over there, our nurse case manager met him and was showing how to use the machine and found that his blood pressure was 198 over 108. So of course, at this point, she encouraged him to go to the emergency room, but he was unwilling to go because he doesn't have insurance and he doesn't show symptoms, right? I feel fine. The silent killer, of course. So she found out that he had been out of his medication for a year, and she decided to go and speak to the providers in the front desk and try to get him in right now. And the provider on staff was able to move him into a scheduled appointment that day. And the patient was seen and got his medication started. And I just thought this is a really recent example of the amazing staff and amazing willingness to go above and beyond, and how these handoffs can really help patients.